Hi, and welcome to episode 253 of the Untethered podcast. Today we have Daniele McLean and Cindy Napoli joining us. They are both Feed The Peds graduates, and I'm going to tell you about each of them separately. Daniele has been a speech language pathologist for 10 years. She's from New Jersey, but resides in North Carolina, where she co-owns a private practice, Tidal Therapy Solutions, providing speech therapy and occupational therapy services focused on sensory and reflex integration, feeding, airway, and orofacial myofunctional therapy in Pender, New Hanover, and Onslow County, North Carolina. Daniele started out with a passion for working with adults with feeding tubes, motor speech diagnoses, and aphasia. She had a placement in EI and a NICU PICU in graduate school, which sparked her love for working with pediatric feeding. Unable to find a pediatric feeding job as a CF, Daniele returned to treating adults until her move to North Carolina, where she jumped back into the pediatric feeding world. Daniele was part of one of the first Feed the Peds cohorts back in 2020 and has taken other coursework to expand her skill set. Following a high-risk pregnancy of her own and delivering her first child at 33 weeks, she knew what to do and how to advocate for her son in the NICU. He presented with tethered oral tissues and feeding challenges, and Daniele really educated the NICU staff on how his feeding challenges were not just a result of being a preemie. He also did not have a speech therapist or a PT in the NICU assessing him. She was the only SLP and mom that really came to his bedside. Her graduate rotation and training in Feed the Peds served her and her son well. Daniele shares her journey with her son on this episode, along with her friendship and professional collaboration with Cindy Napoli, who joins us on this episode as well. Cindy has worked in pediatrics for over 38 years. Her journey began as a physical therapy assistant, working in a variety of settings. That formed her love for a multidisciplinary treatment approach. And during this time, she volunteered and worked on feeding programs, making sure that pediatric patients were positioned well and seated properly to engage with activity demands. Cindy also worked with an integrated preschool, followed by 17 years in a level 4 trauma center in the PICU, NICU, inpatient and outpatient settings with infants and their families. Treating babies with torticollis really became a passion when Cindy's own daughter displayed torticollis signs and symptoms that were missed and undiagnosed by her own pediatrician. In 2018, Cindy returned to school for her graduate degree in occupational therapy while working in EI. She graduated in 2010, continuing to work in EI, mostly school-based, for 5 years, while also teaching pediatrics at the local university for 2 years. She then left to follow her passion working with babies and families full-time. In 2016, Cindy became program supervisor of CHDEI in Springfield, Massachusetts. She's also an educator of infant massage and a CLC. Her specialties include torticollis, plagiocephaly, body tension, functional evaluations with a focus on suck training and jaw-tongue strengthening program as taught in Feed the Peds, along with integrating the use of teaching parents infant massage, positioning at the breast, and bottle feeding, and coaching parents on developmental milestones and everyday play activities.
Quick disclaimer, all information, content, and material of this podcast are the opinions of the speakers and is for the informational purpose only and not intended to serve as a substitute for the consultation, diagnosis, and or medical treatment of a qualified healthcare provider.
Welcome to the Untethered podcast. I am your host, Hallie. I'm a certified myofunctional therapist, feeding specialist, podcaster, business owner, and mentor. This podcast is all about getting your questions answered and collaborating with colleagues to bring you the most up-to-date information in the orofacial myofunctional therapy, airway, tethered oral tissue, and pediatric feeding therapy space. If you're new here, I challenge you to keep an open mind and join my mission to spread this message far and wide. If you've been around since June 2019, thanks for being a loyal listener. As we jump into today's episode, remember to listen with correct oral rest posture. Tongue up, lips closed, teeth apart, breathe through your nose. Let's get started. Daniele and Cindy, welcome to the podcast.
Thank you for having us.
Good to see you.
Good to see you too. You know, it's fun because there are some people who have obviously taken Feed the Peds that I then get to talk to on social media quite frequently. And so to actually be like face to face with both of you at this point is exciting for me. So I'm glad that I get to see your beautiful faces.
Same. I'm excited. This is great. Thank you.
I know I feel like we're constantly texting or keeping in touch, but to actually see you in real time and talk, it's exciting.
We're real people. Yay. So I want everyone to understand, a bit about who each of you are, understand your backgrounds. And, like I said, you took Feed the Peds, but, Daniele, if you want to go first and share with us a bit about, your background and your journey into feeding, I would love for you to start there.
Yeah, so actually, when I first became a speech language pathologist, I wanted adults. That's it. No children. I wanted all feeding, all adults, all strokes, dysphagia, everything. And when I was in graduate school, they basically told me, you can't have your mind decided already. We need to switch this up on you. So when I was in graduate school, they put me through an early intervention rotation and they put me through a NICU and PICU rotation and changed my life. But of course, as you graduate and you get a clinical fellowship, that's not always the easiest to get into. So I was in the adult side for quite a bit. And then when I moved down to North Carolina in 2019, I had the opportunity to start a pediatric department in a clinic. And that's when Feed the Peds popped up. And it just, it opened up my world to pediatric feeding and everything that I do now. And it just has been a game changer, especially in the area that I live in, because there's not many providers who do it. So now every speech therapist I meet, if they ever say they're interested in the tiniest bit about feeding, I'm like, Hallie Bulkin, Feed the Peds, my own membership, all of them. Like, you need to do it. It'll change your world. And it really has. It just kind of gave me so much more information than I ever received in graduate school, because you don't learn certain things at the graduate level, so they give you the basics. So this was really just so knowledgeable and detailed, and it changed my life for me professionally and personally.
Well, thank you for that share and for, giving us your background and everything. And, thank you for promoting me and all that we do over here. And so Cindy, before we dive in any further, will you go ahead as well and share a bit about you and your background in the feeding world and, anything else you want to share with us?
Yeah, so my background is started really different. I actually I still am a PT assistant, and I graduated way back in the dinosaur ages of 1985. And I worked in an institution at the time, working with the pediatric patients that were 18 years old. And I used to help out in the feeding programs. And, back then it was looking at their posture and looking at how they were sitting, but I would help them with their feeding. And I really enjoyed it. And when I used to then work in the preschool and, the hospital, again, I would always volunteer like my extra time at lunchtime and just be part of babies feeding. Like if you needed an extra hand, I would help feed. So that I just really, really enjoyed. And then about 2008, PT assistants were allowed in Massachusetts to become part of early intervention. And I decided to go back to grad school for OT because I just wanted to do more with my life. I wanted to do more in the feeding world. And I felt I really could do it. And I just fell in love with early intervention. And so working in early intervention on the weekends helped me to go on and further my education. But there's just so many opportunities, so many different things. When I went to grad school, I didn't get the chance to do any feeding. So I worked in a school system, but in the school systems in our area, they don't work on feeding. And then I worked with geriatrics. And at that time I was in the stroke unit and cardiac, and they didn't do any feeding. So I was like so disappointed. So when I came back to do early intervention, we still didn't have a lot of kids on our caseload with feeding. Fast forward, after taking your course, that's all I do is feeding. Like there was a time in my life where it's like, I wanted more. I just wanted more feeding. I took 5 different feeding courses and I just still didn't feel like I had enough feeding courses. And I just wanted more. COVID happened, but I signed up for Feed the Peds before COVID happened. And so trying to take your course and trying to manage everything in life, it didn't matter because I was so like in tune to the course. Like the course was like the, I don't know, cherry on the cupcake. It's like you looked forward to it every Tuesday and Thursday. Like it didn't matter that life was chaotic and crazy and you had to figure out your patients. It's like you wanted to go to that course. You wanted to see what was going to happen. You wanted to see how those babies were going to progress from week to week and learn and ask the questions in the live group when you could ask the questions. And I tell everyone it changed my approach to feeding. Like it totally changed everything I do in feeding.
Well, thank you. Thank you for sharing that. I mean, it's one of those things where when this big vision came too, and I actually decided to put like my Myo course on the back burner for a while and create the ped feeding course first. I was overwhelmed because, I was like, this is so much bigger than the knowledge base that I have. And, yes, maybe I've taken a gamut of courses, but the actual kids that I'm working with at a certain point were primarily toddlers. And then I got into infant feeding, but it was more so those cases that were tethered oral tissue, they had tethered oral tissues and they mouth breathing and they were struggling to feed. And very rarely did I get like a medically complex case. Like I had some very medically complex cases, but they were few and far between. And so I just was like, I'm not qualified to teach all of this. Like if I'm going to do this, like I need other people who do this on a regular basis. And that's where we pulled together a team, which shape shifted between like the first days of talking about the course creation and actually getting the first course out just because of a pandemic and people being like, I can't participate in this right now. And I was like, but it was really critical to me that we pulled together like this comprehensive course that I felt like I never had, that I always like wished that I had. And so to be able to actually pull that off and then to meet, therapists like yourselves, and then to watch everybody evolve, like even for therapists who were, our goal was initially like newer therapists, people who are newer to feeding. And then we started to hear that other therapists who have been doing feeding for a while were like, well, hey, like we're taking the course too. And we're like, that's so cool. And to hear that it actually was like helpful in teaching some new, some of it was a review, but other stuff was new, or you were seeing things through a new lens. I was like, this is really, really cool for us. And we also saw like a whole change over time, just critical thinking, right? How everybody was thinking and putting information together and the evolution of it to the point where like now in future cohorts, people will say, well, hey, I have questions about X, Y, and Z. And we feel like we're often saying like, we promise it's coming, just wait, like that conversation, the information is strategically happening in a certain order. And we know it feels like a long time to wait, but like, this is going to be a completely different conversation in 2 weeks after you've watched like module 5 or module 7 or right. And so we're always like, we promise we're not pushing you off. This is where we can't have the conversation we want to have right now. Give it a few weeks. So so it's been very, very cool to be on this side of things and, be able to watch therapists evolve and watch therapists really step into, a lot of them sometimes have the competency already, but really step into being more confident and really going, oh yeah, okay, I knew some of this and I knew a lot of it actually. Now I've got some new stuff too. And like, I really feel like I can go out there and do it. So that to me is like very rewarding to see.
Well, I also think that your course teaches some of the top-notch new wave thinking, even though you've been doing this since 2020. So it's going to be 2024, 4 years graduating, right?
Yeah.
And I'm still hitting roadblocks with so many pediatricians, so many ENTs. I feel like I'm a broken record. I counted since we graduated at least 10 kids that I've referred and have gotten diagnosed with airway issues just from taking your course and knowing the signs and knowing, what to look for. And that's so important. And I say it shouldn't come from me, but those are things that should be red flags for, people right from the start. So I feel like we're educating, pediatricians, they're listening, but it's frustrating at the same time that everybody's not at the same level. And this is, to me, it's old news, right? But it's not, So you elevated, and I love the change of your name. You elevated my awareness to want to know more. So now I have a lot of the baby sleep books or the baby airway books, like all these different things that I never would have thought about before, and we've changed the way we ask questions and intakes. Like our developmental specialists are asking questions about, does your baby snore? Like intake questions. We're going to that level of just, and it's not coming from me. They'll come back to me and say, hey, I think you need to come see this kid. He snores. He has open mouth posture. I noticed he's dribbling. Mom's not concerned, but we're concerned. And I'm like, I just went to heaven. I'm like, I did something right.
It's working.
I'm on the opposite end of things. I'm so badly trying to talk to providers in the area about snoring and airway and tonsils. And everything. And that's been a big challenge for me down here. So my private practice now, that's kind of been our goal, is to have meetings with the providers in the area and teach them what I do and why I do it and red flags to look for. And to the ones that we are actually meeting with, it's like all of a sudden a light bulb is going off. Well, why, how come we never thought about that? But for sure in this area, we're still trying to very much educate on that, because when we're talking about snoring or open mouth posture, a lot of people are like, well, that's no big deal. They've been doing that for how many years? And, you know, you just, like Cindy said, you brought this whole new way of thinking, this higher level that really can change so many people's lives. So, yeah, thank you.
Well, thank you. Thank you. Thank you both for, trusting in a course that you really didn't have much to go off of, because it was pretty brand new. I think when when you both entered into this space, I remember like launching it like March 16, 2020, it like felt like as the world was like shutting down and nobody really knew what was happening. And I created it like with the intention of it being a course that could work with therapists who are working, but that also helps spread the information out, because it's a lot of information. And, I also, just knowing myself and how I learn best, I was like, I like the audio, the visual. I like being able to go back and like rewatch things or re-listen. I literally created the course I wish that I had for my own brain.
And I rewatch it all the time. I really do. I'm constantly going back to it for the kiddos that I treat, for my son. I'm constantly going back to it. And just being able to have that access is amazing.
Module 7 and 8. They play well at the gym when you're on the treadmill.
I love that. That's so funny.
I mean, honestly, it's about 4 years old, but it's 4 years new. I pick up something every time. And, I when I talk about it too, there's one early intervention in our area that I went to speak, and I'm like, I love it so much, you guys. If you don't go to the course, listen to the podcast. You can pick things up on the podcast. If you do the 5-day screening, you're going to learn more in the screening than you have ever learned at any college course. When I was asked to come back and teach last year for pediatrics, I said, no, I can't, because knowing in my heart now how much there is to teach for infant feeding, there's no way I can teach it in 3 days. There's too much. I mean, this is, every college should teach what you teach. This should be required. And there's just so much to know with infant feeding. And you just have done such a great job with it. And I feel like I carry such a level of confidence when I go out. But I still refresh myself. I still, elevate myself to take more courses because I want to know more.
Yeah, lifelong learner.
Yeah, oh yeah, definitely.
But I think that's why a lot of people shy away from infant feeding and pediatric feeding in general, just because before you, there really much education, and the graduate programs are trying to cram everything in that they can. And like I went to a medical college. I went to New York Medical College, and it was based strictly off of medical. And I remember my year there, they did like a trial pediatric feeding course because so many people were starting to really get into it and interested in it, but they didn't follow up with it. And I know that's why a lot of us never felt so comfortable, and we were always so scared. So just like Cindy said, I think this needs to be at a college level for sure, a graduate college level. Absolutely.
Yeah. And I would agree with that fully. And Danielle, so you also had your own experience as a mom.
Yeah.
Would you be willing to share with us a bit about, really whatever you want, anything from the pregnancy to, feeding journey and all that?
Yeah. So I had a high risk pregnancy, and so I have underlying Ehlers-Danlos syndrome, which a lot of people still do not really understand what that is, but it's a connective tissue disorder. So I'm hypermobile. I have a heart condition. There's some other things that can go along with it. So my pregnancy was very high risk. I had intrauterine growth restriction. So my son was born at 33 weeks because of all the complications. And when he was in the NICU, the first thing I noticed, the second I saw him cry, I was like, oh, no, he has ties. And he didn't just have a tongue tie. He had a tongue, he has a lip, he has a lower lip, and he has the upper and lower cheeks. So I'm like, oh, of course, it's like my worst nightmare. So while in the NICU, it was really interesting to me that while we were there, he was never looked at by speech, never looked at by PT, never looked at by OT, and it was just me. Now here I am as a new mom, my anxiety crazy high. I'm in the NICU because he was in the NICU for over a month. There's all this other stuff going on. And on top of it, I was the one training other nurses how to do feeding, or I was the one kind of, hitting the doctors on, hey, I think my son has this going on. Hey, I think we need this type of bottle. They thought I was crazy. So I brought my own Dr. Brown creamy nipple bottles into the NICU. I showed the nurses how to do the pace feeding, all of that, talked to them about ties, to the point where other nurses were coming up to me asking me, what happens if a kid's doing this? And I wouldn't have known how to do all that unless it was for the Feed the Peds. And then, so we got him home, and I found a provider in the area from the Feed the Peds alumni group, and she is 2.5 hours away. Dr. Holman, great dentist. So when my son was 40 weeks and 10 days, we brought him to Dr. Holman for just an upper lip and the tongue release. At that point, we didn't do the cheeks or anything because there wasn't much research out back then when we did it. And, here I am, a new mom, and also my son's feeding therapist, because there's not many people in the area that can do what we do. And that was really hard for me. And it still is really hard for me. My son's healing was not great. He has reattached. He kind of now presents with a partial release, and I work on function with him all the time. And part of it, I think, is because he might have an underlying issue. But being a mom and then having to be a therapist, I can see my kids that I treat and be, just know exactly what to do and how to do it. But then when it comes to your own child, you really are just so blinded by what's the best thing to do. But, he still is having some difficulties. I'm still working with him. He's very orally defensive right now because of everything I've always done, I think. And, right now I'm just working with what we got. I've talked to Cindy a bunch of times, actually, about what to do. Do I get a revision? Do I not get a revision? I know right now is not the best time because he won't even let me look at his mouth. I still do some different things with him, but I think that, I think there's one thing definitely missing in our area, in our specialty, is what do we do when a child might present with some type of underlying connective tissue disorder when their healing is just not ideal? Do we revise? Do we not revise? And then you really have to weigh out the pros and cons. And I think that's what brought Cindy and I together initially, was me asking questions on the Feed the Peds group. And then we started texting, and that's been a big, question mark for me. And, is it worth it or is it not worth it? Because we're talking about scar tissue. We're talking about, more reattachment, all these issues. And I definitely think there's something to say regarding healing, and something I've never really thought about fully until my son's healing was just a mess. And here I am doing all the exercises exactly as prescribed, exactly as you taught us. And I'm like, well, it came back, and it came back a little bit worse. And then here I was as a clinician looking at these parents like, are you really doing the exercises? And now I know, at the end of the day, a lot of it has to do with the anatomy and physiological functioning of the patient, whether it be a child or an adult. And I just think that's something just so fascinating about our bodies, and something I've been really looking into, and, reaching out to other professionals in our field about their experiences with that, and if they're doing any research on that. But long story short, it's definitely been challenging being a mom and a speech therapist. And my son has gross motor issues and low tone and torticollis and all these other things combined, that it's been really hard to kind of separate the two. And that's why I think Cindy and I really hit it off, because we can just talk about this kind of stuff all day long and give each other insight, whether it be from my son or her patient or a patient of mine. And, Yeah, that's my experience with it though.
Well, thank you for sharing that. I mean, I know from one mom to another who has had, feeding challenges and tethered tissue cases, it's not easy, and it's especially hard when you have to be your own, you have to be the mom and the feeding therapist, simply because there maybe is not somebody nearby, even if you want it to be somebody else.
Yeah.
I also have a low tone connective tissue issue. Like, we think that I also have EDS. And when I healed from my own tongue tie release, admittedly, I did not do all the over the head lifts from somebody else doing it that should have. I didn't realize at the time that that would actually be a big deal for me, but especially given like my own connective tissue and lower tone, presentation, that was probably extremely important for my healing process. Or I probably should have asked for some sutures, but I didn't. And so when my tongue healed, I do have what feels like enough range of motion from a functional standpoint. I do sleep with my tongue up in the top of my mouth if I'm not congested, my mouth is closed. And so from a functional standpoint, I've been able to work through, and I did do some adult expansion too, but I've been able to work through a lot of it to the point where I'm functional. But when I look at it, it doesn't look the way I want it to heal. So instead of healing in like a diamond, it healed in a triangle. And so it wasn't necessarily, for me, it wasn't necessarily worse off, but it was like, to put somebody through this and maybe not understand that healing may be very different from one person to the next. It was also a very big eye-opening experience for me. And I completely agree with you. This is not something that, one, that I really think I understand well enough myself, but that two, is very well documented, discussed. It's definitely missing. And I don't know, Cindy, I know you've talked to Danielle about this. Is there anything from an OT, and I know so you also have like your PTA background, is there something you can share or any insights you have on this topic?
So Danielle and I talk a lot. It all started way back when with that straw question. She asked a straw question on Feed the Peds wall, and nobody was answering it. And so I gave her the protocol, and then I just decided, heck, I'm going to text her on the side. And then we've been texting ever since. And she's like, can you give me some ideas? My son has torticollis. And I'm like, I can't give you any ideas for him. I don't have a license in North Carolina. So, but I can coach you on what you can do. And I'm like, I'm so ethically bound to everything my license say, so I'm like, I'll tell you ideas on what you can do. But as far as the release goes, because I went to a study group with Michelle Emanuel too, and she was saying the same thing. Like, you can release these kids as much as you want, but you're going to get the same response if they're not actively participating in the stretches. You may not get that lengthening, right? And then I was talking to one of my providers because I went out to dinner with her, and she was saying, even if you got stitches, you still have to do the stretch. Yeah. So from an oral aversion standpoint of view, and as being an OT, I would say stay out of his mouth. Like, let's use food as a way to reinforce the strengthening. Let's use food to get his tongue to come over. He likes vibration. So let's think of techniques that we can use to get better elongation, weight shifting in the mouth. So I'll use all my therapy terms of what I would do on the floor. But really, it's about safety in the mouth, right? What do we want his mouth to do? As far as the speech stuff, go back to some of the talk tool courses that you went to with, doing the tongue exercises. I think we both took the same course this summer. We seem to take the same courses, where you're doing like the tongue hugs and you want the tongue tip lateralization. So you're promoting the range of motion he has. He might have a partial release, but he also might have a little bit of weight shift and weakness that you see throughout his whole body that we typically see with kids with torticollis. So torticollis is a passion of mine. I absolutely love it. And it's because me as a mom, I was asked by my PT, my longstanding PT that I've been working with for 35 years, who now works with me at CHD in early intervention. She asked me if my youngest daughter had torticollis, and because she had a picture, I have a picture of her on my wall at work, and I'm like, no, there's nothing wrong with her. And she's like, well, she always has her head bent. And I'm like, well, that's her cute baby smile. You have to remember, 25 years ago, torticollis was a diagnosis. Like, you usually had hip dysplasia, you had a bunch of other things going on besides just a crick in your neck, right? So I went home and I looked at her, and now looking back and everything, you read now, she had a traumatic birth. She was a C-section. She almost died. She had the cord wrapped around her neck 3 times. I had a very bad birthing process with her. She was a container baby because she's the first generation of kids that were containers, were strollers, were car seats. But I couldn't lift anything because I also had a gallbladder surgery 5 weeks later. So like that car seat, stroller, backpack, whatever, saved my life, right? Saved my lifting. So literally, she truly had a positional torticollis, right? Nobody calls it that anymore. Pediatricians aren't taking the time to say and to refer. So we got these babies with all this body tension. What I've learned from going to Feed the Peds course is the connection between torticollis and tongue tie. And that's the other thing that you drove me to, Hallie, is I needed to know more what that connection was. I needed to read more. And the more I read, the more I researched. I wrote up my first evaluation. I was so proud of it. And one of our area providers said, I can't accept this from you. You're not a CLC. And I'm like, I'm a feeding therapist and I'm an OT and I took a course. I know what I'm looking for. I did a functional evaluation. I'm asking you to tell me whether these are oral restrictions and or tongue tie. I said, I know they're restrictions, but are they tongue ties? Wouldn't accept the evaluation. And I'm like, you know what? I'm going to go back and I'm going to better myself. So that's what drove me to become a CLC. And, I'm so thankful for that remark. I finally got to meet him in person a couple of weeks ago and I thanked him. I said, thank you very much. Now he wants his referrals to come from IBCLCs. And I'm like, I'm too old.
Oh my gosh.
Like, look, I do the body work on them. I am a PT assistant. I'm an OT. I work with the PT. I teach the parents in massage. I'm like, I do my best that I can. I said, I'm very confident on what I'm doing. I said, I'm sure that you can take this evaluation and gather that I've done a good job, because I actually won't refer a child on the first time that I see them. It takes me 3 times to do the evaluation. I want to make sure that I'm accurate, concise. I also want to see if the baby responds to therapy, because a lot of times, you actually will see a difference if we can get their tone down and their tension released. I can really see what the flora of the mouth is doing. And that's changed over time. That's taken me a little bit of time. And I have to thank Dr. Andrea Fallon. She's one of the preferred providers I've been working with, who let me come and see a release. And, she'll say, Cindy, I love your paperwork. I know when you refer your clients that these clients are ready for a release. They get a much better release. The muscles you can just see, and I'm not caught up in the fascia because they're getting what they need. So, I would love to educate more on, we need to be in their mouths before and after. That would be like my ultimate. If everybody knew that, I would be happy.
Well, it was interesting too, Hallie, because you and I were texting about my son way back when, about what to do and how to help him, because he also has all these allergies, and you were trying to help me try to calm everything down for the healing. And what's funny enough is, where I live, just trying to get PT involved for torticollis or infant massage or craniosacral therapy, it is so difficult in this area. And, as we all know, they all go hand in hand with feeding issues and tethered oral tissues. And I just think it's so interesting how we have all this knowledge, but it's not spread everywhere. And it really makes such a difference for everybody. And I have a tongue tie myself, and I'm looking to get mine released by the same provider, but I had to do my son first. And I think of everything that you were just saying too, Hallie, like how is my healing going to go? Because my son, he's pretty functional, but his tongue doesn't look the greatest. And it's just so interesting when you think about everything together from everything you taught us. So just really fascinating.
Yeah, and I think like one of my biggest messages and things that I realized going through this as a mom, as a parent, as a provider was how interconnected everything is. And that conversation that you've both highlighted is just it's lacking in, and look, there's Eastern medicine, there's Western medicine, there's people who live in between both, there's people who use both, there's some people who are more one direction than the other. At the end of the day, we're all dealing with the human body, right? And we all, I think, need to come to the realization that, like we've been talking about, it's so interconnected. And it almost, before I even had conversations with other providers who actually validated this for me, before I realized there was like a book called Anatomy Trains, and before I realized that like, this is a like real thing. And it just was like my intuition. Like I kind of was like, well, if our tongue is connected to our hyoid and our hyoid is, I was like, it's like this bone's connected to that bone kind of thing, the little song that plays in your head. I like had a new song in my head and I was like, this is influencing that and that's influencing that. And I'm like, this is connected down. I'm like, well, the kids are not chewing their food well and they're swallowing these whole pieces of food. Like a lot of these kids are on the spectrum that I was working with in my earlier days as a therapist. And I was like, and they're always constipated. Well, maybe they can't chew their food well enough. And if they're swallowing whole pieces of food and it's making it down to their belly and the belly can't process it, I'm like, well, that's connected. Okay. Now what about the kids? I had all these conversations like happening in my head. I'm like, well, what about the kids who are chewing well enough and they're still having constipation issues? I'm like, but again, it's all interconnected. Like, why are they not having regular bowel movements? Is it the type of foods they're eating? Well, yes, we know for some kids, like they have very limited repertoire. And so it is the type of food. And is it that the foods are too soft? Is it that the foods are one single color and we're not getting a good diversity of foods here? It was just really made my brain start moving. And then when you enter into that whole sensory oral motor conversation beyond just the type of foods, but how easy it is to break a food down, how much are we chewing, how much energy does that take? I'm like, then I started looking at these kids and I'm like, the kids who are falling apart by snack time at 10 a.m. are the kids who have used up like 9 of their buckets of energy and we've got 1 left and they cannot possibly sit here and chew another snack. So they see the snack and they are like in fight or flight because maybe they need the energy, but they don't even have the energy to consume it to gain additional energy. And it was like, I just had all these like conversations in my little ADHD brain, like webs of conversations going in 5 different directions, going like, something is going on and nobody's talking about it. Why?
Yeah. But, and then add the vagus nerve on it, right? You just said flight or fight and body tension, the vagus nerve, torticollis. So it's like, it just like all goes together, right? So it's like, you need to soothe it.
And my son's been in PT since January, right? And we're still having issues with weight shifting and that left side, and his cheek tie and everything is much tighter on that left. And I always kind of describe it as a pulley too, with just the tethering and how the body's trying to fight it. And, it's just crazy how all this stuff makes so much sense. But it took a while for us as a profession to get here and understand it and talk about it. And and that's why I think it's just so important to educate and enlighten everybody on it and what can we do to help provide therapy for these people.
Yeah. And something that one of our sucking skills, right? The infant training skills that we do, after we do our vows and everything. I bought the book for Christmas last year by Catherine Jenna Watson, or Catherine Watson Jenna. I always get the 2 names mixed up. But, she pointed me in the direction, and I took a couple of her courses too. And it's like looking at the tongue and looking at the tongue lift. And she does a lot on torticollis and breastfeeding and how you don't fight that baby to have to feed in midline. Like you really do the comfort of that baby's neck position and you just slide them over to the other side. You don't try to get that perfect head position, which kind of like blew my head away. But it's like when you do that, it's like just so much more comfortable for the mother and the baby. But taking pictures has been like so complimentary to all of my evals and actually attaching them to the evaluations. I'm actually seeing, like, we'll just take pictures randomly when the baby's crying, and you can literally see the tension and the lift in the tongue and how asymmetrical not just our jaws are, but the tongues are. So you can tell the jaw tension by the tightness, right? How long does it go in? Where is it going in the fingers? How tight is it with the phasic bite? But the tongue lift is so telltale on it can't lift this high on this side. It's lifting over on this side. It's like there's so much work to be done. So much work to be done inside the mouth.
Yeah. Well, on those babies, right? I always say when they're crying, and I always say it sounds so cruel, but just get a video, get a video or a picture, because like you said, you get so much information from that and what the tongue is doing. And more times than not, just by seeing what they do when they're crying, right? You kind of go like, okay, I have an idea of what's going on or not going on in the mouth when they're feeding and when they're at rest and when they're, when they're needing to function, there's dysfunction present because of what we're seeing right here. And it even carries over in older kids, not necessarily older kids, like preschoolers even, where by the time they start chewing, right, we can see on their face that a masseter muscle is more developed on one side sometimes than the other. And we go, I know what side they chew on. And I can tell you the tongue is probably not lateralizing. They're probably putting the food in on those molars. They're chomp, chomp, chomping, munch, munch, munching. And maybe there's some overspill onto the tongue or into the cheeks, but they're probably not getting a whole lot of food on the other side unless they're placing it directly on those molars on the other side and then swallowing it back from the molars. And so it's so fascinating to me, like when we start to just look at like tons of faces, and that's what I've always said. And I know during the pandemic, this was challenging, but it's like, get your hands on as many pediatric faces, whether you're working with infants or toddlers or older kids as you can, because as you start to see these things and then you can actually like palpate, and kind of feel the muscles and what happens when they punch down, what happens when they open their jaw, what happens when they're feeding or they're, whether they're breastfeeding, bottle feeding, cup drinking, chewing, whatever, swallowing, what does it feel like? Because it's so fascinating, like to just feel like you're like, oh, yep, that's a pattern that now I've seen in a number of these kiddos. A lot of them have very similar dysfunctional patterns that, to your point, Cindy, like there's a lot of things that we can do to help them. Obviously, we need to know where the dysfunction lies. But yeah, like how, we don't diagnose on the visual, but that visual is so critical. And it's always been like one of my best teaching tools because we can't see it all. Like I can't see it all when working with a child. I will record and go back after and be like, whoa, totally missed that when they were sitting right in front of me and I was looking right at their face. Like,
It's true.
Yeah.
Yeah. So now you two connected in the group as you shared, and you guys have a lot of commonalities and topics that you are very passionate about. Feeding awareness, especially like in your own communities. I know, Danielle, that you shared a bit about like your community. Now, Cindy, like in your community, do you find that like, are there a number of feeding therapists? Is it lacking? Like, what is it like where you are?
Yeah, I feel like it's lacking. We have a great group up in Northampton that will see some outpatients, but where I work right now, it's an inner city, so a lot of our families don't necessarily have transportation to go up to the Northampton area. So I think that's a little bit hard. But there are several early interventions in the area, but anybody age 5 and over, so for the older population, it can get difficult. It can get really difficult for these kids. I only treat 0 to 3. So, it's hard. A couple of the hospitals will treat, but it's very short term, so there's not a lot of variability in feeding therapists. There's not a lot out there. We're starting to make some headway with like, a couple places have some sensory gyms and some sensory spot areas that will offer open play and open access and do sensory evaluations for kids and things like that, which is really nice for the area. But there's not a lot of private, feeding therapy and things like that. So.
And I also think it gets kind of touchy too, just kind of expanding on that, right? Because food is comfort, food is love. And that's when I come from a big Italian family. So when you're sick, you eat. When you're happy, you eat. Everything you do revolves around food. And not only do I think there's a lack of it in the area as far as feeding therapists goes, but I think there's, it's a little touchy of a subject when you talk to a parent that, oh, your child is having a feeding issue, or, your child can't move their tongue the way they should. And I think it's a little touchy of a subject too. So I think that's why it's also kind of not so known, not only just because of the lack of providers, but I just think the touchiness that comes to it. And if your child eats everything, a lot of times people think, oh, they're fine, there's nothing wrong, but we look at it differently, right? Or a lot of times regarding the airway, I see older kids too, and a lot of them have attention deficit issues, and a lot of it's coming from that airway, and trying to, explain that to a parent or a physician, it can get a little touchy. So I think that's also kind of the reasoning for it being not so big as we want it to just yet.
Yeah, I mean, I think there's that dance between like the art and the science, right? Of like delivering information, especially when someone's not asking for it, but like you are working with the child, and it's like I feel like I have an ethical obligation to discuss this with the family. And I think part of it, surrounding food, especially begs the question of like, where's the education for us about being culturally sensitive and being culturally competent clinicians? Like, how do I even ask the right questions to not offend this person? How do I deliver this information? And, and look, at the end of the day, if they're not interested in addressing it after I brought it up to them, like that's their prerogative, right? But it's such a fine, like, dance between that, because I'm Jewish, and we have a motto in my family, till we eat again. Like every time I see my family, it's like till we eat again, because everything centers around food, whether it's a birth, a holiday where we're fasting and then we break with a fast at the end of the day, death, like everything, celebrations of all kinds, like everything is somebody had surgery, somebody's husband got diagnosed with something happened to the child. Where can I send a meal? Is there a meal train? Like, how do I, like, nobody wants you to have to worry about feeding yourself or your family. There should never be anything but enough food, right? And so I totally, totally get like where you're coming from too. And it's, as like a mom also, for like someone to say something to me, I think, as a feeding therapist, like, okay, I get it. But I always try to put myself in their shoes to be like, whoa, like this is something we don't touch. Like we don't mess with this. And at the same time, we're like, but I also want my child to thrive. So like, what's that marriage between, being very sensitive to, and also being an ethically, appropriate clinician? It's an interesting conversation.
Yeah, it's definitely a dance. We definitely teach that. When we talk about responsive feeding, one of the topic areas that I bring up is, how do you feel about feeding? How do you, as a human, feel about feeding? Did you have trauma in the past? Because many of us did, being Italian, who you finished your food. And it was we always had a happy time eating, but, we also came from different pasts. It's like you finished your plate club, and if you didn't, you went to bed early, and, food mattered. And when I was brought up in college, it was like, desserts were rated the same as your mealtime, which I do agree with. It's not finish your plate club anymore. So trying to pass that along to new parents and new therapists, it's like, you got to kind of understand where parents are coming from, kind of read the room. And also, like, if we're talking about baby-led weaning, or even having that conversation with how are you going to feed your baby, what's the next steps of transitioning your baby from the breast or bottle into solids? One, are they going to believe you? Are they going to believe the pediatrician? Like, I just come out straight and say, this is what the American Academy of Pediatrics says. This is what the WHO says. 6 months is when we start feeding and introducing solids. And this is how I feel. I'll give you the data on it. And this is the reasons why. But then when we start talking about, the baby-led weaning or adaptive baby-led weaning, and you're talking about a lot of food waste, right? Some of our parents can't afford the food waste. So how do you have that conversation that we're going to value this, right? We're going to value the baby bringing food to their mouth, but at the same time, how do we do it so that they don't break the bank, but they can still manage it and do it lovingly, right? And then if they don't want to do that, how do we not judge them for not carrying out what we say? So it's a lot of checking in with yourself as a therapist, and not using implicit bias or using noticing your own implicit bias, right? And going from there and saying, okay, what's best for the child? What are the parents' goals, and how do we meet that together? Because sometimes we might have these great grandiose goals, but the parent just, wants to do what they want to do, but let it safe for the baby.
Yeah. Well, and I think that's a beautiful point because, it's one of those things where you really have to check yourself, like you said. And it was before I even had children, I oftentimes would try to take a step back and go okay, don't have their lived experience. What, when a family says to me, I respect what you're saying, but we don't want to do that. That can hit your ego a bit, right? And you kind of go oh, but do you actually respect me? Do you actually trust me? You start to have these conversations in your head. And I think a long time ago, I just based on some of the populations I worked with, I very early realized that not all families, like you said, can afford food waste. And even sometimes those who can, maybe are not okay with it, or maybe they have their own ways of dealing with it. And so I really think, like you mentioned, Cindy, it's our responsibility to put our egos aside, check our implicit biases, our biases, to make sure that we are being sensitive to who we're working with, because at the end of the day, you're not helping anybody. If I'm pushing my agenda on a family, I'm not there to help them. I'm there to push my agenda and make myself feel good, right? And so that's why I say it's such a dance between art and science, because we have to put on our creative hats and go, okay, what I normally recommend is not going to work for this family because it just, they have certain cultural beliefs, or they have certain, monetary or dietary guidelines or restrictions, or whatever the case may be. What can we do to help this child, like you said, be successful, meet the parents' goals, and do it in a safe way? So I love how you framed that, because it's really important. If it's not more important than everything else that we do, families are not going to step forward and trust you or want to work with you if they're not being heard. And so, especially in this day and age, we have a big responsibility to lead that conversation. And I think, my eyes were very open to marrying my husband, who was born in Belarus in communism, and who, food waste is not a thing here. We don't throw food out. But I also I always have this thought in the back of my mind of I'm not in the clean the plate club, committee. That's not where I live. But I will take food from our table and I will put it in a glass, container, and I will put it back in the fridge and we will eat it tomorrow. And, where one of my parents grew up in the either clean the plate club, you have 7 minutes to eat, the plate gets picked up, 7 minutes after I put it down on the table. And if it's not done, like you said, you go to bed early, or you don't get anything else the next morning, you don't eat, too bad, go to bed. So it's there's so many, whether that's trauma that's been embedded into our experiences. Or when I was growing up, I felt there was always enough food. There was no limitations on how much time we had to eat. My brother was usually the last one at the table. He was a kid who liked to carry 2 cookies around, one in each hand. He didn't always eat them. Maybe he'd eat one, but he didn't eat both. It was whatever that was, right? Everybody has these experiences that they come with, and they may not want to talk about it, but I think giving the space to open conversation around what's, like you said, what are your experiences? What are your beliefs? What is important to you here? Is something that we definitely need to discuss more and elevate more. And I actually had a phone call with the CEO of Asha yesterday, and we were talking about just things happening and some change that we want to see internally, and some things that we're doing, externally as members. And we brought up the conversation around feeding, drinking, swallowing, and these different cultural, religious, conversations, and just understanding how to even approach that conversation. And she did share one resource, but it's become very apparent in the past couple of months that we need a lot more. And I think that, it then falls also on us as therapists to support our colleagues in approaching these topics and these conversations.
Yeah.
Yeah.
So now, after that heavy topic,
It's a good one.
let's move forward. And Cindy, I know you also, you give talks, you teach on some level, right, at the local university. So talk to me about, I think, Danielle, did you attend some of Cindy's talks that she gave? Talk to me about that.
Yeah. So Danielle came as as a mom and as a SLP, I think you came to the first one, right? Because the second one you ended up having to work because your employees were sick. But so I gave a talk on torticollis and the connection between torticollis and tongue tie, and then an intro to, what was the other one? We did intro to baby-led weaning and adaptive baby-led weaning, which is the one you weren't at, right?
I was not at that one.
What was the other one?
Or like tongue tie release and
The
torticollis,
first one was torticollis, feeding issues, what to expect, or what do you see,
Yeah.
and how to like recognize all of
Mm-hmm.
that, and what role it plays in with feeding and just overall development.
Yeah. So yeah, so we talked about that and really gave them, what does it look like to breastfeed? What does latch look like? What does a good breastfeeding session look like? What does a shallow breast latch look like? And I think some of them like had no clue like what the tongue was supposed to do. I mean, I know, and I use the Farquhar, Dr. Farquhar, the ENT videos that you had on, and I even found the toddler videos. I love his site because he has multiple tongue tie videos, and I used those videos, and I don't think people realize like what the tongue function is really supposed to do. So even when I was taking classes as a CLC, like people will ask me, like how did becoming a CLC influence your job as a feeding therapist? I said, becoming a CLC has helped me learn about breastfeeding and supporting the mom and knowing what a good latch looks like and knowing how a baby should come on the breast and off the breast and everything I should know about a mother and the signs and symptoms. So I think that has helped me greatly. And I talk a lot about that. Like, you need to know, like as an OT, you can take classes, you can go to different courses that offer lactation and OT, but being a CLC really tunes you into the science of what might be happening inside that breast, what might be happening with the mother's emotions. And again, being an OT, you can do all that counseling. So it really goes hand in hand. Mm-hmm. But as far as the video goes and the tongue mechanics of the breast and where the nipple is supposed to be on the palate, that I can't even tell you how valuable that is. And then showing the students that and making them feel where their tongue was on their palate. And, they were just like amazed as to where it was supposed to rest. And then seeing the toddler video and seeing what a normal bolus goes. And then if the tongue doesn't rest on the palate, what happens to a typical high palate? And it's like, I always tell parents that it's their choice to go to the ENT or to the dentist to see if their child needs a release. I don't diagnose. I will state what restrictions I see. I state how it interacts with their function. And if you choose not to have the release, we need to compensate somehow. So we need to make the feeding safe, whether it's a bottle, whether it's the breast. We just need to make sure the baby is safe. We're going to find out like between 6 and 8 months when that baby can't eat mashed potatoes because it's not going to be able to form the bolus and make the little dump truck tongue go back and push it back into the throat. And they're all amazed. They all come back to us at 8 months going, something's wrong with my baby. It's not eating. And it's like, just little birdie told me. Little birdie named. Yeah. So it was really amazing. But what I liked in the second presentation was that it actually shows, why with that high palate up there, and if the tongue can't move, they panic, they get stuck. There's nothing you can do. And that video is like priceless. It's like, you guys may not go into any infant feeding, but if you go into adult feeding, pediatric feeding, if your tongue is stuck to the base of your throat or the base of your mouth, this is what happens. And this is why you get kids that panic and that become picky eaters. And every kid that you see that comes to your clinic, please check for their tongues. Please check for restrictions, because I can't tell you which I like more. Seeing the babies get done that take about a month. I never tell patients that it's going to go away right away, because it still takes about a good month for a good suck training to complete. But let me tell you, some of my older toddlers that get done, it's almost incredible how quickly they begin chewing and having a diagonal and rotary chew like within a week. It's night and day. And I don't know which I enjoy more. It's absolutely incredible.
All the progress, all the progress. Well,
Crazy.
and yeah, it is. It's absolutely incredible to see it
Yeah.
happen. And we see the patterns, right? Working with these little ones, like we see the patterns, we know, like, okay, they're compensating well now. Like, when
Yeah.
is this going to change? We know it may be around 4 months, 5 months, 6 months, 7. I mean, at some point, a lot of them will come back and I'll tell parents like what to look for, which it sounds like you're kind of telling them very similarly. And they'll come back and they'll be like, how did you know? Like, how did you know that like this would have been one of the things? And I'm like, I kind of do this. Like, this is kind of what I do. So, see these patterns and see these things happen regularly. And I wish it for nobody. I'm like, at the end of the day, I hope that you don't have to come back. I hope that everything, works out well. But anatomy and physiology are kind of one of those silly things that we might have to work on.
Yeah.
Yeah. So Danielle, you had mentioned that with your little one, where he is now, you mentioned you're still working on something. So what are you guys currently addressing, if you're okay to share?
Yeah, so I'm still adjusting his facial tension because of the upper and lower cheek ties. He definitely has a lot of facial tension. So I do a lot of massage. I try to do the cheek sweeps and all the pulls. And like I said, he's really not letting me just recently not go in there. I do a lot with the vibration tools to help with all of that. I'm working on his biting, his lateral biting. Everything he prefers is on the right, so I'm trying to get him to prefer and bite on the left, but he tends to go with his head versus just biting, so we're working on that. And I'm still trying to teach him how to slow down. He likes to overstuff because of the low tone and because of the difficulties that he's having. So we're getting lots of speech and language work in with making him wait and having to request more. But a lot of it is coming from just, working on the tone, working on the strength and the function, the range of motion. And then also as well, this is another thing too. I know too, as his core gets better, his hips get stronger. That's also going to play a part in his jaw strength and function. So it really just goes hand in hand. So as we're working on that, I know they will kind of correlate and work together. But it's a lot of really working on that oral defensiveness too and making it a lot more fun and play. So eventually, maybe in the future, we can get assessed and see if something needs to be done, but just so that I can work on his function. A lot too with my finger, with the vibrating tool, I'm trying to get his tongue to do certain movements, lateralizing, elevating. The one thing I was just talking to Cindy about was I had cookie day on Sunday and we made peanut butter balls and I gave him some to try and that actually got him to work on suctioning. So I was like, all right, if this works, we're going to do clicking and we're going to do elevation and suctioning. And that worked. And I was able to see the frenulum and it's there, it's pretty thick, but he's able to do that and hold it for a couple of seconds while doing the peanut butter ball trial. So that made me ecstatic. But I think it's just getting creative and trying different things to work on oral motor skills. Like I'll give him corn on the cob, I'll give him ribs, I'll do different things that really require biting and opening up your lips more and rounding and stripping. So it really is getting creative with the food that you give to your child to make it fun and you're not really just in there with tools too. So I do a lot of different food items that require a lot of biting and pulling and opening his mouth more, which helps in general. So I did a lot of that too with our baby led weaning when we, instead of giving him things to like chew on, I did a lot of like, I would take a corn on the cob and take the corn off so he can practice. So there's just, and that's what I teach my parents too, I just think it's more functional that way. So that's what I do, and that's what I've been doing.
Love that. I love that. So you obviously have not obviously, but you have a private practice. So tell everybody where they can find you. So if they're looking for someone in your area.
Yeah, so we're definitely hiring, actually. We're looking for an OT or a CODA or a SLP or SLP assistant. So we're a mobile therapy company. We are located in Holly Ridge, North Carolina. And we treat all the way from Wilmington, North Carolina to Jacksonville, North Carolina. We provide treatment in the homes, the daycares. We're partnered with the Early Intervention Program of North Carolina. So we see a lot and we do a lot. You can find us on Instagram. You can find us on social media. And we have a website. It's TitleTherapyNC, as in NorthCarolina.com. And we also have some posts on Indeed. But you know, I have a couple of speech therapists underneath me that they're going to hopefully be taking the next Feed the Peds course that comes out. So yeah, trying to train everyone on how to do some feeding stuff too, which is great.
I love that. Yay. And we'll make sure that that's linked in the notes so that everybody can link directly to you if they're anywhere near you or want to work with you. That's
awesome.
A fun opportunity.
I actually did find one person through the Feed the Peds alumni group.
I love that. I've actually found team members through there as well. So yay for that. Cindy, how about you? If someone wanted to find you, where do they find you?
So basically, if they need an early intervention referral, we work in the Springfield area. So we have 5 catchments. They can call CHD and look up chd.org. Our number is 739-3954. And then I am opening a small private practice for people that are not in my catchment area, which would be Agawam, Southwick, West Springfield, and Westfield. And they can find me or email me at cindy@goodlatchot.com.
Awesome. Well, thank you both so much. I know we could stay here and talk all day, but I don't want to take all your time. I know that, Cindy, it looks like you're in the office. So
I am.
Got your cute little baby behind you over there.
I know. And we're so excited to be sending one of our new employees to you too. So she knows she's going to be the mini me, which I'm happy for because I can't keep up. We're getting so many referrals, which is awesome.
Yeah. I mean, there's such a need. And so anybody who is interested in, obviously, Feed the Peds, you can reach out to us at support@feedthepeds.com. We're happy to help. Reach out to Danielle or Cindy, ask them all about it. But yeah, if they're in your area and, somebody wants to either work with one of you or just a parent that wants to connect with you, I really encourage you all to do so because Danielle and Cindy are both amazing resources in their areas. And at this point, I would just love to clone all of us 100 times over so that all the babies and all the families, and all the caregivers can access the care they need as soon as they need it and speed up that process too, really get those little ones in there as soon as we know there's something going on and increase awareness.
I truly feel like we're changing the future of picky eaters. Yeah, I really do.
Yeah. I always say it's not picky eating if it's been going on for more than a couple months. At that point, there's something greater that we should be kind of going why? Why is this happening? Because I always say kids want to be successful at what they do. And they're little people pleasers. They want to make us happy. They want us to be proud of them. They want us to clap for them and be like, yay, great job. Right. And so no child is, and I say this too, as we're wrapping up and I'm going into a new conversation. I say this because we get a lot of families that call and I'm sure you hear it too, where they go, oh, my child's just a lazy eater. Oh, my child is stubborn. Oh, my child is, this, that, just a lot of descriptors that we go, please stop using those because I can promise you that your child, this may feel very challenging for you. And I'm not in any way, shape, or form trying to, tell you how to feel about the situation. However, children inherently want to be good. They want to please, and they have 2 basic functions in life. They need to be able to breathe and they need to be able to eat. And if they can't do those things, they're not doing it. They're not struggling on purpose to piss you off. So if we can all take a deep breath and realize that children really want to eat and breathe, maybe we can all kind of come to the table and have a different conversation. But yeah, we get those phone calls all the time that they're lazy, they're stubborn, they're this, they're that. And I'm like, can we just stop that dialogue and move it to a different conversation? So yeah. Anyways, any last thoughts before we wrap up, ladies?
No. Sorry, you're going to hit my son.
Thank you guys both so much for joining me.
Yeah, it was great seeing you again.
So great talking to you guys.
Thanks for listening to this podcast. If you found value in this episode and want to hear more of these MyoTots airway and feeding related episodes, be sure to leave a review on Apple Podcasts and share this episode on your social media platforms. You can access free resources and all I offer at halliebalkin.com or pop over to @HallieBalkin on Instagram to get all the latest updates.